Okay, so this is our cardiac nukes talk. So just going to start out with a brief didactic portion, then we'll do some cases. So the general idea when you're doing cardiac nukes is that the agents, majority of the agents, the common agents, are blood flow dependent or they're perfusion agents. So normal myocardium that's getting perfused normally, give them the tracer, it's going to take it up and it's going to get hot. Abnormal myocardium, you give them the tracer and it's not going to take it up, or at least it's not going to take it up the same as normal myocardium. So when I say abnormal myocardium, what do I mean by that? Well, I mean that it could be ischemic or it could also be scar. Because obviously ischemic myocardium is not going to get the same blood flow as regular myocardium, and certainly scar isn't either. So it's going to be relatively cold. So how can you tell those two apart? Obviously that's a big difference, right? And the way you can tell them apart is by doing rest and stress imaging. So if it's cold on both rest and stress, then that's scar. And if it's cold only on stress imaging, well then that's ischemia. That's not scar. That's what they call a reversible finding. So just the general principle on this is that you've got a lot of reserve. So this is a normal person, just sort of supply and demand. You're sitting on the couch watching this lecture, you're resting, and your heart is not it's not pumping that fast. Now obviously hearing my voice, it's probably pumping a little faster than it would be normally, but it's not pumping as fast as it would be if you were, let's say, running from a zombie. But you can't really, the difference isn't noticed because you've got this big supply that can meet a big demand. You know, your heart, a normal heart is ready to roll for action, so it's got a lot of reserve. Now, a diseased heart, you may not notice that it's diseased when you're resting. Like, people don't have angina when they're just sitting on the couch, usually, unless it's unstable, right? So, but if they start walking up the flight of steps, then they have chest pain. That's because they have no reserve. The general idea is that if you've got stenosis that's 50% or less, you won't see a defect until it's under stress. And to see it without stress, it has to be extremely critical, like 90%. In other words, you stress people to increase the sensitivity of the exam. So how do you stress people? The common modern agent is this regadenoson. That's what's done that's the most common modern agent. So how does that work? It's a vasodilator. It's not just a vasodilator. It's specific to like cardiac vasculature. It's a specific receptor there. So it's not supposed to have as many of the pulmonary side effects. So you don't get as much bronchospasm and stuff like that. So the old one was adenosine. So let's just compare these quick. So new versus old. They're both vasodilators. Like I said, it's more specific, less bronchospasm. The old one can cause bronchospasm and can also cause AV block. This is a rare side effect, therefore it's testable. This is testable too, obviously. That's probably more testable because it's tricky. Caffeine, you have to avoid caffeine for this exam. That's part of the prep. That would make a good question. Which of the following would you avoid as part of the prep? And there'll be another follow-up question regarding this, which I'll talk about in a second. If you're forced to give an antidote, that would be amiophylline. Now, remember, people who write boards exams secretly want to be family medicine doctors, so they're obsessed with medications and medication side effects because they want to tell their mom that they're a real doctor too. All right, so what about this guy? Probably remember this from med school pharmacology. If you don't, I'm going to review. This thing inhibits the breakdown of adenosine. Remember, adenosine is a really short half-life, and because of that, this allows for it to build up sort of like an SSRI, causes serotonin to build up. And increasing that amount there, then you've got a vasodilator. So it works sort of as a secondary vasodilator. It works in conjunction with adenosine. The trick to know, this is highly testable, is that amyophilin's half-life is actually shorter than this, so you have to continue to monitor or give a second dose if somebody was having side effects like bronchospasm. So what if you did take some caffeine? Or you had an allergy or something like that where you couldn't have adenosine or products that build up adenosine. You can also stress with dobutamine, and it works differently. Instead of acting as a vasodilator, it increases the contractility and rate of the myocardium. And remember, this is a beta-1 agonist. 1 because you've got one heart, beta-2 agonist because you have two lungs. So beta-2 agonists are for lungs, beta-1 agonist for heart. Why would I dare even bother bringing up a pharmacology mechanism? Because people who write test questions want to be family medicine doctors. Well, there you go. So who do you give it to? Again, someone who has a contraindication to adenosine, someone with COPD or asthma because of the bronchospasm side effect, or the caffeine thing. The thing to remember here is that the patient cannot be on a beta blocker to use dobutamine because it is a beta agonist. So if you have a beta blocker, you're blocking the mechanism of the drug. Ideally, patients should be off beta blockers, calcium channel blockers, long-acting nitrates 24 hours prior to the exam, because all of these meds can mess with the sensitivity of a stress. Unless, and there are certain situations where you might want to keep people on these meds if they're getting specific risk stratification on medical therapy, but for the purpose of multiple choice, they would have to straight out tell you that they're on this med for stratification. Then they wouldn't make any sense to even ask the question like that. If medications come up, they should, the beta blockers, calcium channel blockers, long-acting nitrates should all be held for 24 hours because they mess with the sensitivity of the exam. Another thing that messes with the exam is eating. So eating 4 hours prior to the exam is a no-no. And the reason that you tell people not to eat 4 hours prior to the exam is because it decreases GI blood flow. So you've got less blood going to the gut, so you've got more tracer available to go to the heart. And gut tracer can cause artifacts and just generally decrease sensitivity. So no eating 4 hours. That's the mechanism that makes it easier to remember. And hold the meds. So what are your options, generally speaking? And the reason that I'm rehashing that again is because I'm using some different vocabulary words here. So vasodilation, that makes sense. But this chronotropic, ionotropic agents, be like, what the hell does that mean? It means dobutamine. Okay, this is code. I'm trying to trick you into dobutamine. So without saying dobutamine, you could say these other two words, and that's code for dobutamine. Vasodilation is going to make more sense because that's the mechanism of these agents also. Having said that, the ideal scenario is actually to have the patient run on the treadmill, but most of them won't do it because they're fat diabetics, and they can't get enough work unit things up to speed to get their heart rate up and stuff. So if they could actually run on a treadmill, they wouldn't be in this situation to start with. It's their anti-treadmill lifestyle that's put them in this situation where they need to use a stress test. So here are your tracer agents, and there are a few other tracer agents we'll talk about later in the talk, but these are your big-time tracer agents, and these are your perfusion agents, although thallium has sort of a functional component that we'll talk about later too. Basically, they diffuse into the mitochondria. This is MIB. Remember MIB we talked about in a parathyroid talk. Blood flow plus mitochondria. This is my mitochondria cartoon that I drew. And tetraphosphamine is the more modern agent. Works similar to MIB. It's supposedly better because it's cleared from the liver more rapidly and decreases the chance of artifact. So that would be the difference if somebody would ask you what the difference between these two is. Thallium, Early on, you have blood flow issues that bring, more blood flow, more thallium, less blood flow, less thallium. But then also remember the mechanism is that it's sodium potassium pump dependent, so you requires a living cell to move in and out of. If it's dead, it doesn't have a functional sodium potassium pump, because remember that's an active transport pump. It requires ATP. I talk about this in the pulmonary lecture with regard to things that are alive having, like Kaposi's, for example, taking up thallium, lymphoma taking up thallium in the brain, versus gallium inflammation that doesn't work like that. It's more nonspecific. So remember, thallium requires something to be alive because it uses a sodium potassium pump, which requires active transport. So here's your three general views: short axis, vertical long axis, and horizontal long axis. Now, if you've done a bunch of, so programs vary. Certain programs, cardiology dominates this stuff. They dominate the cardiac imaging completely, and you maybe have seen a few of these. Other places, radiology dominates, and they do all this shit. You probably have done thousands of these things, and you're like, I know what the views are. But there are people who don't. So I'm going to just go through them really fast to orient you on the anatomy. So this is the short axis, sort of looks like a donut depending on where you're cutting. The further out you come, the more it looks like a donut. And this one is the one that I like the most, because it's easy for me to remember the anatomy. Vertical long axis, you're coming through it like sideways. They all sort of look like C shapes. And then horizontal, you're coming through it horizontal, which is the easy way to remember that. And they also look like C shapes, except they're more like an A. It's like flipped. So horseshoe pattern looks like an A, horizontal, and vertical is, you just have to sort of remember that. If you can visualize that in your head, makes sense. This is the money picture. I've shown this in multiple talks, and you have to know this, guys. You cannot, please do not drop questions on this. You have to know this. It's super easy for them to show an infarct or ischemia and have a follow-up question on what's the vascular distribution. You need to know it for cardiac MR because you have to be able to distinguish between, hey, that's a non-vascular distribution, so that means that that's amyloid or that's myocarditis or that's sarcoid or whatever, versus that is a vascular distribution. I'm thinking of ischemic heart disease. So bunch of ways this can be asked. You cannot let this go. So this is your short axis here. This is your horseshoe that way. All right. So let's do some cases now. I'm just going to go through some super basic stuff, and I'm going to hit on some trivia and some things I think are testable. So we've got short axis views, stress and rest. They'll show that they have to show that, and they have to label them as such. And what you're looking for is defects that are either reversible or non-reversible. That's one of the things you're looking at. Okay, so we'll start there. So let's get a zoom in and a close-up here. And you can see that on the stress, it looks like that part there doesn't fill in as much. The donut's more complete. These things need to look identical, guys. Very close to identical for you to call it normal. And they're not going to show you a normal unless they want to ask you a tracer question. Even then, I don't think they'd show you normal. So we've got a reversible defect, and remember that that is ischemia, right? So when you challenge it, you're seeing that that reserve's not there. There's something else that we're seeing here too. So this is a follow-up. So if you look at the center of the donut, that donut actually gets bigger on stress relative to rest. And that there's a name for that. I think this is something that's more likely to be asked, which is transient ischemic dilation. It's when it looks, the donut hole looks bigger on stress than it does on rest. So the tissue is still there. It's just there's ischemia, diffuse ischemia to the endocardium. And if you remember from the MR lecture, the wave of ischemia goes in this direction. So if you're going to have the wave in this direction, it's gonna hit here first, right? So that's the part that would be ischemic first early on, and it's just diffused the whole way around. So things to remember: what it is, what it looks like, the fact that it's seen with subendocardial ischemia, and the fact that it's multivessel disease or left main, which is basically two-vessel disease, right? So it's the whole inside of the donut. So remember, it's all the vessels. You look for it. It's worse on stress. Of course it would be, because you're challenging it. All right, so what about this one? We've got, let's get a zoom in here. All right, so we've got a stress and rest images, and we can see that there's a defect that's present on both stress and rest. So it's a fixed defect. So when you say fixed defect, that's scar. But there's more to it here. So let's look at the morphology. See how that sort of looks pointy and that looks rounded? So there's a fixed portion, and then there's a portion that's also reversible. And that is called peri-infarct ischemia. So that's something sort of second level. That's minimally tricky if you've never done this before, never heard of it before. That's what that looks like. All right, so moving into some more sneaky stuff. Let's get a zoom in here, short axis. The donut looks big, right? It's a big hole in the donut, and it's present on both stress and rest image. So it's like a fixed big donut. So the donut hole that gets bigger just on stress is that transient ischemic dilation. This isn't transient. This is present on both. So it's dilated. This is dilated cardiomyopathy. And you're supposed to say fixed dilated cavity. So I say fixed dilated cavity. You say dilated cardiomyopathy. I say transient dilated cavity. You say transient ischemic dilation. And then you say multivessel disease. So this is a non-ischemic heart disease. Dilated cardiomyopathies are like your holiday heart, alcohol stuff, chronic alcohol, post-viral Coxsackie virus, pregnancy-related heart diseases is dilated cardiomyopathy. So it's like toxic shit got in there and poisoned the heart, and it's like fixed, dilated, and it doesn't contract normally. All right, here we go. Here's another one here. So we'll get a zoom in. I'm just showing you normal compared to this, which is too much. Too much, man. You don't usually even see the right ventricle, right? It's rare to even see the right ventricle, but like if we go back here, especially on this one, man, you are seeing a lot of heat in the right ventricle. So when you see ventricular uptake, right ventricular uptake that's anywhere near the left ventricular, then you're thinking that's RVH. There's more to it, though. Let's take a closer look here. This would be an even sneakier way to talk about things. So, you know when you've got you're doing a CTPA and you've got a positive PE scan, after you find the clot, the next thing you're supposed to do is look for right heart strain, right? And how do you look for right heart strain? You look for flattening of the interventricular septum. Some people will call that D'ing out, like making the letter D. So normal here looks like a circle. Flattening or D'ing out that ventricular septum is seen with right heart strain. So this is somebody who's got bad pulmonary arterial hypertension, one of the big causes of right heart strain or right ventricular hypertrophy. So big right-sided heart, hot right-sided heart. Think about pulmonary hypertension. Think about COPD. If they would make you go into like a neck, like what is this patient, what underlying disease process does this patient have? That would be like a second step or third step, tertiary step question. Or they could make it easy and just ask you what the finding is, which is RVH. Should not really see that right ventricle. If it looks like an 8, then it's RVH. So let's compare three pictures here. And I got normal labeled for you. So we've got, this is a normal appearance of the septum. Then we've got this one here where the septum is big, right? It almost looks like he's been pumping iron, this septum here. And then this one, it looks like if we drew a line here, he's missing part, right? And he's getting cold up through here. So this one, we've got like a septal defect, almost like there's ischemia here. I'll tell you a trick that's not what's going on. So hypertrophic cardiomyopathy, this is a way to show it. That would be very sneaky, but big, fat-looking septum. You can see that on nuclear spect also. And then this is the classic left bundle branch artifact. If you knew any artifact regarding cardiac imaging, this is the one I would know. I think it's the most testable. The other common ones would be like diaphragm artifact, where it clips the bottom of the heart, or breast attenuation artifact, which can really clip any part of the heart. Respiratory motion, they'd have to show you that the person was breathing, and then you'd think anything could be wrong with that. So those are the ones you see all the time at the view box, and if you've done any cardiac imaging at all, you've seen that like over and over and over again. The left bundle branch block one is the one that you sort of have to do some reading for. I think that's the one that's most likely to be asked. So here's what you need to know about that. Left bundle branch block is a reversible or a fixed defect involving the ventricular septum, and it spares the apex. So it's not going to extend into the ventricular apex. It's just going to be that back portion of the ventricular septum. That's what you need to know. Okay, so tricky verbiage here. Tricky verbiage. Some things that people get confused. They get this backwards. They don't understand this. I can remember this shit on step 1, asking this stuff on step 1, and I didn't really understand it well at the time. Feel like I understand it better now. So let's talk about it. I'll straighten it out for you. There's stunned and there's hibernating myocardium. Well, what's the difference? There is a difference. There's a whole bunch of differences, and it's testable. So I want you to think about stunned myocardium as like this guy. He's a boxer that got knocked down. Now he's not knocked out. He's just got stunned. So he's seeing Tweety birds. He's seeing stars. He's stunned. He's still alive. Nobody would say that guy's dead, right? Be like, you see him getting knocked down and be like, he's dead. No, he's not dead. He's just stunned. Versus this. You go into the bear cave and you see the bear, and the bear is just laying there. Is the bear dead, or is the bear hibernating? I don't know. I'm not sure. I'm not going to try to wake it up. But if you see a sleeping bear and he's really in a deep sleep and he's not snoring, you might maybe think that was a dead bear, or maybe he's just hibernating. You can't tell. And this is the way to remember this and the way to think about it. So stunned is still alive. He's just hurt. Hibernating, not sure if they're alive or not. So with stunned myocardium, the perfusion is normal. He's still alive. It's normal. But the contractility is abnormal. So this is something that happens acutely too. Like he got hit, okay? So he's been hit with a right hook or a left hook. He is stunned acutely from the strike, and now his contractility is abnormal. He's got wobbly legs. But the perfusion is still normal. It's still normal. Hibernating, the perfusion is abnormal. So you would think that, hey, that could be a scar, right? And that's the main differential with hibernating myocardium. Big difference here also is that stunned myocardium is acute. He's acutely responding to that strike. Hibernating myocardium is a chronic, long-standing hypoperfusion, so that it's different. So big differences to know. Stunned, perfusion, normal. Contractility, abnormal. Hibernating, perfusion, abnormal. Contractility, also abnormal. And it is chronic versus acute. So I mentioned thallium before. Think about thallium early on as a flow agent or perfusion agent, like that. More blood flow, normal thallium, abnormal blood flow, abnormal thallium. And then later on, think about it sort of as needing this sodium-potassium pump to move in and out of the cell. Remember, that requires a living cell that's active transport. And just think about this as this redistribution phase. So we've got two different situations here. One where we've done our stress imaging. Okay, patient A, patient B. And both of them are showing a defect here, right? Agree? Same defect here. And so we read this and we said, could be scar, could be hibernating myocardium. And so a thallium examination was ordered to tell the difference between the two. So early thallium works just like the stress imaging, and think about this as like the flow phase here. So same defect, remember, less blood flow, less thallium. But then on a delayed image, it's going to, that sodium-potassium pump is working, it's going to redistribute in reverse. Whereas if it was actually scar, it would, it's dead. It doesn't have active transport, so it's not taking it back in. So PET can be used, there's PET can be used for cardiac stuff also. And you can think about PET as either having perfusion agents like rubidium or ammonia, or metabolism agents, which thallium sort of is, right, where it's proving that it's alive through that sodium-potassium pump, and that's like FDG. So FDG can also be used in a setting of, is that a hibernating myocardium or not? Rubidium and ammonia can be used for flow calculations and stuff like that. You can do some fancier stuff with it. Some trivia to know about rubidium is that it is made in a generator, just like technetium is. So that's a really good question because that is unique for PET agents, rubidium made in a generator. So let's review these three here, just like we talked about with thallium. And we're going to do FDG versus ammonia. These are two different PET tracer agents. Remember, FDG is more talking about metabolism, and this here is more talking about flow or perfusion. So stunned, what do we say about stunned when it comes to perfusion? Stunned, the guy's still alive, right? Nobody's going to say that guy's dead. He's obviously still alive. He's just stunned. So perfusion is normal for both of those, and it's still alive, so it's going to take up the FDG normally. Now, hibernating, remember, you can't tell if he's living or dead when it comes to flow, so that's going to be down. FDG may actually be up. Some people will say it's normal. Some people will say it's up. It can be either up or normal. Don't get it twisted. If you're forced to pick between, I would actually pick up. But you'll see it written both ways in most books. So that's the main difference. And then obviously scar is dead, so it's not going to take up either one. Now, a couple of more things here. So this is a, you may see something, anytime you see a lung and heart ratio and it's a cardiac thing, this is like an old school thing that was done back in the Cretaceous period. The lung-heart ratio for thallium, basically if there's more tracer in the lungs, thallium's not taking it up. So that means that there's not good flow to the heart. So that's multi-vessel disease. So a high lung to heart ratio equals multi-vessel disease. All right. Speaking of multi-vessel disease, so let's take a look at this one real quick here. And we've got stress over rest here. And these guys, they looks pretty similar, right? Maybe a little bit going on here. Man, we're looking pretty similar here as we go through. How about if I told you this guy has severe three-vessel disease? Well, how would you know that? Well, maybe he has an EF of 30 and he has global wall motion abnormality and his EKG stress was positive and he has every risk factor known to man. You see something like this, you should say balanced ischemia. In other words, if it doesn't make sense, think balanced ischemia. What the hell does that mean? When you're comparing stress to rest, you're assuming that that your rest is normal. But if you're comparing cold area to another cold area, remember, if you get like 90% stenosis, you're going to be abnormal even on rest. So if you've got really bad ischemia and it's balanced, it's not going to show up. So how can you tell? The next answer is to use a perfusion agent. Remember, that was rubidium, which is made in a generator, by the way, and ammonia. Those would be your perfusion agents, and that's how you can tell if it's balanced, because it can calculate this coronary flow reserve, which gives you a quantitative number. So instead of just comparing, this looks the same to that, you actually get a number which you compare to a normal value, and then you can say that that's low. So that would be a utility for using PET. That was the non-FDG PET, the flow-related PET. So one last thing, I showed this case on the parathyroid lecture because it's a MIB trace. Remember, MIB likes two things, blood flow and mitochondria, and that's why MIB is also used for breast-specific gamma imaging, because cancers also have blood flow and mitochondria, so do axillary lymph nodes that have cancer in them. So if they're showing you a heart and then they're showing you tracer uptake in the chest wall of a female, that's a breast cancer. If it's in the axilla, maybe still a breast cancer, could be other kinds of cancer, but MIB is on the no-go list for lymph nodes. It's abnormal if you see it in lymph nodes, and the next step would be an ultrasound or something where you biopsy it. You can't let that go. You have to think cancer first. So this is the end of the talk. Speaking of breast cancer, the next lecture series will be a breast cancer series and benign breast stuff. It'll be mammo time.